Okay, just share my screen. Okay, can you guys hear me? Okay, sure. All right. Thanks a lot for coming, guys. So today we'll be covering recipe, phys, and clinical skills. And I'll be covering recipe phys first, then RJ will be covering clinical skills in the later half of the session. Yep. So hope you guys are going well. This is just a meme, and I think we're all feeling around a 5. Yeah, I'm feeling 6. All right, so we're just covering recipe phys, and today we'll be covering alveoli and the body part of recipe phys. So just be covering the alveoli part first, and in which there are two main segments. There's a ventilation part and there's a perfusion part. And under ventilation, there are tools that you can use to measure it. And under perfusion, there are tools that you can use to measure perfusion as well. So, yep, ventilation. So I guess the first question you have to ask is what controls ventilation, right? And really what you need to know is this thing called the Fick's law. So Fick's law states that the diffusion across the capillaries is based on 4 factors: the area, the thickness, the diffusion constant, and the pressure difference. So I guess they are pretty self-explanatory. The only thing that really needs explanation is diffusion constant, which is basically like the type of gas that you are talking about. And in most cases, it won't change. So usually that will be constant and the same value. Pressure difference is basically like the difference in oxygen. For example, if you're talking about oxygen diffusion, the difference in oxygen pressure between the alveoli and the capillary. So if there's a bigger difference, then the diffusion will be faster because there's a bigger concentration gradient. Yep. So the clinical relevance of this is that there are different conditions that can affect the different factors. So for area, that could be your emphysema or your emboli. So emphysema, it's like because when you smoke, then there's like insult to your alveoli. So it will degrade and overall the surface area decreases, and that will decrease the diffusion rate in general. For emboli, it's because when there's an embolus, then that certain part of the lung is not perfused by blood, and therefore you can consider it like a dead space. And because of that, you have a decreased total surface area for diffusion. For thickness, there are 2 conditions. So there's fibrosis. There are 3 conditions: fibrosis, edema, and ILD. So essentially, fibrosis will thicken your wall. Let me just draw it real quick. Fibrosis will thicken the walls over here, and then it will make it difficult for oxygen coming outside to diffuse. For edema, same thing. There's a layer of liquid inside here, and because of that, it's also a thickened wall and difficult to diffuse. ILD is a similar concept as fibrosis. So for the pressure difference, when you give oxygen, then the concentration of oxygen is bigger inside the alveoli. So there is a bigger pressure difference because P1 increases. Yep, and diffusion is faster, and then changes to blood flow as well. So if blood flows quickly, then there will always be a low concentration of oxygen in the blood. And because of that, P2 decreases, and overall your pressure difference increases. Yep. So hope that makes a bit more sense to you. Okay. Does edema reduce area as well, or is it too thin to make a difference? Yep. So I think it does decrease the surface area, but I think the main thing is the thickness. Yep. That's the main focus. Okay. Next up. So here is the here are the different pressures of oxygen and carbon dioxide throughout your body. So I guess the values are really important to know because Monash likes to test this, and it came out in my year, I think. Did it? Yeah, it did. Okay. So you don't really need to know the nose, but what you need to know is the alveoli and the blood vessels. So the oxygen and carbon dioxide, when you move from the nose to the alveoli, essentially the air that you breathe in is very rich in oxygen and very poor in carbon dioxide. But then as it goes down your tract, then it gets like diluted with other air. So because of that, it becomes 140. This is a very important value to know. And then subsequently, as it moves on throughout your body, then the oxygen will overall decrease until it reaches like 40 in your blood vessels, and your carbon dioxide will increase as it like collects carbon dioxide from the rest of your body, so it will increase. Yep, and then the veins are also similar to the blood vessels over here. So I guess a few things that I would want you to know. The first thing, this just for understanding, is why is it that, carbon dioxide, there's only a partial pressure difference of 6, but then in oxygen, there's a partial pressure difference of 60. Does that mean that because partial pressure difference is bigger in PO2, therefore diffusion is faster, and therefore, is there a different amount of oxygen and carbon dioxide coming in and out of your alveoli? And the answer to that is that CO2 is actually more soluble in water. So because of that, it is the amount of CO2 that gets diffused across your alveoli membrane is actually a lot more. Yeah. So so that's the first part of it. Second part is regarding these altitudes. So if you have a higher altitude, then overall your PO2 and your PCO2 will decrease in the alveoli because atmospheric pressure decreases. And then overall the concentration gradient is less across O2, but more across CO2. And then the converse is the same for lower altitudes. Yep. Okay. Moving on. So how do you measure ventilation, right? There are two main tools that you use. One is the oximeter and the other is an arterial blood sample. In clinic, what you really use is the oximeter because it's just like this little finger thing by the bedside. But the arterial blood sample is used in more severe cases. So what you really need to know is this normal range result, which Monash can test you, and the ICU point as well, which is the point where your patients experience hypoxia, which is 90 and 60. Yep. Okay. So that measures the amount of oxygen and carbon dioxide in your blood. And the next tool is a DLCO tool, which honestly, I tried learning the mechanisms behind it, but it was so low yield. What you really need to know is that a low DLCO means that you have a poor alveolar capillary membrane, which in layman terms just means that it's difficult for gases to pass through the alveolar and capillaries. All right. So now I'll just move on to perfusion, which is the second part of this segment. So under perfusion, there's this thing called the VQ ratio, which I think you're all very familiar of. VQ ratio essentially states that in order for effective diffusion to occur across the whole lung, the perfusion and the ventilation must match across different levels. And a good ratio is 0.8. So here's just how I think about it. And this is also an important concept to know. So ventilation actually decreases. Ventilation is actually lower on top as compared to the bottom. And how I think of it is like a slinky. So if you imagine like I dangle a slinky like this, right? Then the top part is very expanded and the bottom part is very scrunched up together, right? So what this means is that um, the the top alveoli is not able to expand much. There isn't much room for it to expand, while the bottom is able to expand by a lot, right? So it's kind of like paradoxical, but yeah, that's how I like to think of it. And because of that, the ventilation at the top is only very minimal, but the ventilation at the bottom is a lot. So that explains ventilation. It increases as it goes down. For perfusion, on the other hand, it's another story. So the mechanism I think of is the gravity of the blood. So gravity pulls the blood down, right? So because of that, the perfusion is more at the bottom of the lung as compared to the top. So in other words, you could say that Q increases from the top to the bottom by a lot, right? So what does this mean for VQ ratio? So at the top, if you take V over Q, it's so sorry, let me just write it out first. In the bottom, you have V over Q as well. So the ventilation decreases a bit in the bottom, but it decreases a lot for perfusion. So because of that, your VQ ratio overall will be higher at the bottom and lower at the top. Yep. So hope that makes a bit more sense to you. All right, so I just move on. So I guess why all this matters is because we need to know how VQ ratio changes. So if you look at this graph over here, the VQ ratio actually like increases as it goes towards the apex of the lungs, which makes sense. Gravity and if you exercise and if you lie down, they both have the same effect. So it will cause V and Q to be more evenly distributed throughout the lungs, and because of that, VQ ratio is more well distributed across the lungs as well. So you can look at this diagram, but I won't go into it today. Okay, and the last thing for VQ ratio that you need to know is what a shunt and a dead space mean. So a shunt essentially means a low VQ ratio, and a dead space means a high VQ ratio. And the conditions that cause this are as follows. So a shunt basically means that there's a low V and a shunt means that there's a low V and a high Q. So therefore, pneumonia and asthma can cause like obstruction, and therefore you are poorly ventilated, and that will cause a shunt. For VQ ratio higher than 0.8, so your V is actually more, and your Q is lower. So because of that, a pulmonary embolism, which will decrease your perfusion, will actually cause a dead space, which links to the concept of functional dead space, which I talked about previously. So just to recap, dead space, there's anatomical dead space and functional dead space. And in this case, the functional dead space is the one that's affected. Okay. So for perfusion, there is this thing called VQ homeostasis as well. So in very simple terms, it's basically a way for your body to control how much blood and air goes to each part of the lungs. Okay, so what you really need to know is that if VQ, for example, if I have let's say I have an obstruction, right, and then my V decreases in a certain part of the lung, correct? My V decreases in a certain part of the lung. So for example, my pneumonia and my asthma. So what my body does to react to this is that in that certain lobe of the lung, it will try to increase the V, right, to normalize the ratio. So it will try to increase V and therefore cause bronchodilation. But at the same time, it will also decrease Q so as to maintain the VQ ratio, right? And what that essentially means is that eventually that segment of the lung will become dead because there's low Q and therefore low blood, no blood going into that segment of the lung. And I guess the converse is true as well, so you can work it out yourself. And that is the clinical relevance of all of this. So on the converse side, if you have a PE, for example, a PE will cause a decrease in your perfusion to a certain lobe of your lung. So VQ ratio increases. And therefore, in order to normalize the VQ ratio, I want to decrease my V, right? And so I have bronchoconstriction. And that kind of sucks because that means your lung will collapse in that certain segment. So, yep, this is just a better understanding of how it works. And the tools for this essentially is a CTPA or VQ scan. Clinically, a CTPA is a lot more used, but VQ scan is used as just like a detection kind of tool. So, yep. Okay. And this is probably one of the most high-yield things you can take out of this. So, if anything, here's a cheat sheet for you to basically be able to answer any question in Monash land about spirometry. So I'll just run through this very quickly. Essentially, when I get a spirometry, I'll have two values. So I'll have this and I'll have this. And what I want to find out is, firstly, is my FEV and FVC ratio decreased? If it's decreased, then I'm thinking, okay, maybe it's more of like an obstruction picture, right? But on the other hand, if it's not decreased, then it's more of like a restrictive picture, or maybe your lung is really just normal, right? And there are no pathological changes. So that's the first thing you want to find out. Then you move down the table and then you try to find out what is your FVC. So your FVC most of the time would really like finalize whether it's obstructive or restrictive, right? So assuming your FEV ratio decreases, right? And then your FVC ratio is the same. And then, okay, you should really ring a bell. Okay, it's an obstructive picture. It's an obstructive picture. Okay. But if it decreases, then okay, maybe there's something wrong with inspiring as well. So it's a kind of mixed kind of picture, right? And then subsequently, I would like to double check with TLC. Yep. And then I'll also check my DLCO. So you can recall what DLCO is. DLCO is basically like detecting if there's any problems between the alveoli and the capillaries, right? So if I have an obstructive picture and my DLCO decreases, then I know that I have obstruction of my lungs, and it's because I have shit diffusion between my capillaries and my alveoli. And that points towards emphysema, which, if you recall, is a decrease in surface area and fixed wall. On the other hand, if DLCO is the same, then I'm thinking, okay, first it's an obstruction picture, but then there's no problems with the diffusion across my alveoli and my capillaries. So that means probably there's some kind of like mucus plugging my airways, and then it will point me towards chronic bronchitis and asthma. Yep. So similarly, on the other side, if my FVC is the same, then I'm thinking restrictive or normal. Okay, then I check my FVC. If my FVC decreases, then okay, ring a bell, it's restrictive. If it's the same, then it's probably normal or pulmonary embolism. So, okay, restrictive picture. Now, I check my DLCO, and then DLCO says that, oh, my DLCO is decreased. So that means probably there is some kind of thickness within my alveoli and my capillaries, and it points me towards a more fibrosis kind of picture. But on the other hand, if DLCO doesn't decrease, then it's more of my chest and my surrounding tissues. So I'm thinking more of a chest wall disorder or obesity. So with this, you can never go wrong in the exams when they ask you what kind of conditions it could be. And it's really a lot more systematic than just trying to force memorize everything. I think that's kind of stupid. Okay. So here's just a meme for you. Okay, right. So now I'll be moving on to the body part of RespiPhys. And really, there are a few things I want you to know. So first up will be the transport of gases. So if you imagine across the alveoli and the capillary, what this slide is basically trying to tell you is that diffusion happens very, very quickly in the alveoli. So it happens within the first 0.25 seconds, and the subsequent time that the blood and the alveoli is in contact is essentially in equilibrium. And the clinical relevance of this is that if I exercise and my blood flow increases, then there's like a time buffer for me to play with. Yep. Not that high you, but just fun fact. Okay, transport of gases. So this is quite high you. Monash likes to test this as well. So how does oxygen move around your body? Is essentially via hemoglobin. And for carbon dioxide, the main form is that it will diffuse into the plasma. Yeah, but of course, it can also, the main form that carbon dioxide travels in is as bicarbonate, but there are also other ways that you can transport as listed above. So the important thing to know is this HbO2 curve. So I'll just describe the process for you. This really confused me when I learned it. So let's say you're in your alveoli, right? Okay. In your alveoli, the concentration of PO2 is actually 100 millimeters mercury. Sorry, the pressure is 100 millimeters of mercury. And there's 100% saturation of hemoglobin, right? Because all your hemoglobin has oxygen, right? Okay, so you'll be at this point of your graph. Subsequently, as you move through your body, and then like oxygen gets diffused out to your tissues, right? The pressure of oxygen actually decreases, right? So usually it will decrease down to around 40, if you remember our values. And then it will have a corresponding decrease in the hemoglobin saturation, so it's around 75. Yeah. And then after that, it will move back into your alveoli. And when it moves back into your alveoli, your oxygen inside your blood increases. And then your hemoglobin saturation also increases back to 100. Okay. So that is how this graph works. The clinical relevance of this is what happens if you have hypoxia. So hypoxia is actually rather serious, and the reason why we get these values is because let's just plot it out over here. So 60 millimeters of mercury and 90% saturation of oxygen. So beyond this point, your curve becomes very steep, right? So a small drop in your oxygen will cause a very, very big decrease in your oxygen saturation, and that's really bad because then your body is unable to transport oxygen efficiently, and really you'll get into this hypoxic state. So that's the whole rationale behind the ICU point. Okay, then this Monash loves to test you this, man. Okay, you gotta know this. So how does your HbO2 curve shift? Really, you can try to memorize all these effects, but I like to think of it in simple terms. So why would my curve shift to the right? The one word I think of is exercise. You can also think of Ball's effect, but I like to think of exercise. So if I exercise, then I would have a few things. I will have my body will have more carbon dioxide, so it will become higher PCO2, and because of that, more acidic. You have a lower pH. My body temperature increases as well, and I also produce a byproduct called 2,3-DPG. So overall, if there's any of these changes, it will cause my curve to shift to the right. Okay. And the reason for this is because, okay, look, I'll show you. Okay, so this shows a right shift, original and final, right? So assuming you are at 100, okay, 100 mmHg, and then you move down to your tissues and then you reach 40, right? And I just saw, oh my god, okay, I just stopped it. So you can see that if you compare the first graph and the second graph, there's actually a much bigger decrease in your oxygen saturation. So that basically means that if you exercise, your oxygen is able to dissociate a lot more easily into your blood. And that will really facilitate oxygen moving into your tissues. Yep. And that's the whole reason why if you exercise, there will be a right shift, is so as to increase the efficiency of oxygen diffusion across the body. Yep. And then something you need to know is this thing called the effect of CO on this curve. So for CO, if I increase my CO, then what I like to think of is that a lot of my hemoglobin will now become occupied by CO, which means that I have less available hemoglobin, right? So therefore, the percentage of saturation actually increases, which is why, oh my God, okay, but essentially at 40, right, your, oh my God, wait, shit. At 40 mmHg, there's actually like a much lesser drop in your hemoglobin. Yep. So that's the whole reason behind CO. Okay, next. And when you talk about O2 delivery, there's also another factor you need to consider, which is your VQ ratio. So in cases where there's a high concentration of hemoglobin or bleeding, where there's a lot of blood in your body, then a lot of blood around your alveoli, then essentially oxygen can diffuse more easily between the alveoli and the capillaries, and therefore your oxygen can diffuse more easily and be supplied to the rest of your body. So this is another factor you have to consider. Not that high U. Okay, and the last thing for ventilation is this thing called control of ventilation. So there are two ways that your body controls ventilation. You have a neural control and chemical control. Neural control, it's essentially automatic rhythm pacemaking. Is controlled by your respiratory groups. I didn't really bother memorizing the DRG or the VRG, and it has never come out before, so low U. But you just need to know that the certain part in your medulla actually controls how fast you breathe. And similarly, based on different receptors in your body, it will affect your respiratory group in your medulla, and it will modulate your rhythm. You can memorize these effects on breathing if you're keen, but not that high U as well. Okay. Chemical control. So there are two parts to it. There's central chemical control and peripheral chemical control. So central chemical control actually is modulated by the H plus in your ECF, and the peripheral control is actually like in your carotid receptors. So this will be your carbon dioxide, your hydrogen ions, as well as a decrease in PO2, i.e. hypoxia. Some things to note is firstly that H plus cannot diffuse through the H plus cannot diffuse through the blood-brain barrier. So assuming like the plasma CO2 goes into your brain, right? It'll actually diffuse across the blood-brain barrier as CO2. And then in the cerebrospinal fluid, it will actually become H plus and stimulate the central receptor. So how Monash will test you maybe is they may say, okay, like um, like how does blood H plus affect ventilation? So you need to know that blood H plus doesn't affect the central route because it diffuses across the blood-brain barrier CO2. Rather, it affects the peripheral chemoreceptors. Yep. Okay. And then second thing that you need to know is that the central chemoreceptors have a very, very big effect, but they're very slow. But peripheral ones are very small effect, but they're fast. Which makes sense because it takes time for carbon dioxide to diffuse across your blood-brain barrier. Therefore, central is slower than peripheral. Okay. And this one, you can go read yourself, but it's just 2 sentences to summarize this whole thing. Okay, so that is RespiFizz in a nutshell. And I just got a few questions for you guys. So if you could just type your answers in the chat, that would be great. And I will go through the questions in turn. You can message me privately as well. Mm-hmm. Okay, so I got a few answers. I think I'll just explain this. So the answer is actually D. And I'll just explain each of the options. So VQ ratio is the greatest at the base of the lung. The answer is no. VQ ratio is actually the lowest at the base of the lung. Yep, because V decreases by a bit as it goes down the lung and Q decreases by a lot. Wait, sorry. V increases by a bit as it goes down the lung, but Q increases by a lot as it goes down the lung. So your VQ ratio actually decreases in the lower parts of the lung. Ventilation is higher at the apex than the base. No, it increases as it goes down the lung. Oxygenation of blood occurs evenly across the length of the capillary. No, because as it diffuses across the blood, the rate which it diffuses by actually decreases. And also the concentration of the PO2 actually like increases as it goes down the capillary in the alveoli. So oxygenation of blood is not even. Blood in the pulmonary veins has a lower O2 than in the alveolar capillaries. That is true because in the capillaries towards the veins, the oxygen actually still diffuses out into the surrounding tissues. So blood is indeed lower, albeit by a little bit. As for alveoli, it's not less surfactant. The surfactant actually remains the same, ironically. It's actually an increased concentration of surfactant. So it's the smaller alveoli are generally like a bit more patent than the larger ones. But yeah, just a rare fact. Okay, next. Which of the following will cause a right shift in the O2HB dissociation curve? I'll give you a minute. Okay, so I got a lot of B's, and you're right. Okay. Next. Sorry, RJ. Just for the banter. Okay. Yep. So I think, yep, most of you got it correct. The answer is actually D. And I think I'll just spend like a minute to explain this. So, okay, first clue I have is that he's a 69-year-old man. So I'm thinking, all right, probably not asthma because Archie will go through it later, which is that asthma is more of like allergic kind and is usually like a younger onset for most kinds of asthma. So immediately I'm thinking, okay, probably not asthma. Okay. And the rest are quite likely for old men. So, okay. Next, shortness of breath. Okay, everything causes shortness of breath. So kind of useless there. Upon investigation, you realize that patient has a decreased FEV FEC ratio. So I'm thinking, okay, obstructive. So it's this half of the equation, this half. Okay. And then a normal FVC. So, okay, definitely obstruction. It's not going to be a mixed picture. So, okay, it's probably here, this box. Okay. And then I have a decrease in DLCO. So, okay, there's a problem with my alveolar capillary membrane, probably because my emphysema is destroying the surface area of my fixed law, and therefore my answer would probably be emphysema. Okay, pulmonary embolism is here, fibrosis is here, chronic bronchitis is here, and asthma is probably under the obstruction side, but nowhere to be found. Okay, and unlikely because of 69-year-old man. All right, next. This is the last question from me, and I'll just pass the time to RG afterwards. Okay, 30 more seconds. Oh my God, questions are so fun, guys. Okay, fine, but it's fun setting the questions, not fun answering the questions. Okay, so the answer for this is B. And why is it B? I'll just explain it briefly. So same thing, we read the stem. Firstly, Mr. Pingu is a 58-year-old non-smoker. So, okay, in my mind, I'm thinking he's an old guy and he doesn't smoke. So, smoking, I'm thinking like COPD. So, that's my chronic bronchitis, my small airways disease, and my emphysema. So, immediately I'm thinking, okay, probably not emphysema, but I'm not sure. So, okay, maybe not emphysema. Okay. And then I'm thinking 58-year-old man, 58-year-old man. Okay. So cystic fibrosis is actually like a genetic condition caused by a defect in your CFTR gene. So usually the prognosis is no more than like 20 or 30 years old. And there's a movie called like 6 feet, 5 feet apart, I can't remember. Yeah, but it's basically about two kids with cystic fibrosis and they die in their teens. So that's how I remember, and it's probably not cystic fibrosis. Okay, so who presents to the GP with chronic cough and SOB? So chronic cough, SOB, okay, he has a cough. We just move on. His PaO2 is 81, so it's actually pretty shit, and his SaO2 is 92, so it's pretty shit as well, meaning he's going towards the hypoxic state. His BP is high, so he has hypertension, and his temperature is normal, so probably not an infection. Okay, chest has fine crackles. So what I know is that okay, pulmonary edema, it can cause is a result of pulmonary hypertension. So if there's a hypertension in my pulmonary veins and arteries, then it can clog up into my capillaries and push the liquid out into my alveoli and therefore cause pulmonary edema. Okay, that's consistent with hypertension, not infective. Increases the thickness, therefore poor diffusion, causes hypoxia. Okay, good. Fine crackles, okay, RJ will explain that later, but it's characteristic of pulmonary edema. Interstitial lung disease, probably not. Pulmonary edema is more unlikely, and polycythemia, it's not present anywhere in the stem, so that's very unlikely. Okay, so hope that makes a lot more sense to you. And right, RJ, do you want to take it away?
Yeah, sure. Let me just share my screen.
Yep.
Yeah, so now I'll just be covering a bit on respi clinical anatomy. So it's kind of linked to whatever Anna was teaching earlier. So, we went through a bit of physio. So there are a few conditions related to physio like COPD, emphysema, and I'll just touch up more about that. But before that, let me just go on to cover a bit more from what we covered from last week. So remember we focused on the pleura. So hopefully now you've gone through your embryology lectures and you now know the different pleura. So you've got your parietal pleura as well as the visceral pleura. So your visceral pleura is basically surrounding your lungs, and your parietal is around it, right? So your parietal pleura will receive somatic innervation, and it's very sensitive to pressure, pain, temperature. Okay, and there are different parts of your parietal pleura, so you can name it as your cervical, mediastinal, costal, and diaphragmatic, based on the areas where it's around. And so pain from this area can refer to different areas because due to the varied innervation of different parts of the parietal pleura. So let's just focus on the cervical pleura. So your cervical area is actually your T1. And your T1 dermatome is basically like your medial side of your arm, right? So pain can be referred there. Costal pleura, that's your T2 to T10, and that's basically chest pain. You have mediastinal pleura, that's your phrenic nerve. So that kind of refers pain to your tip of your shoulder, your jaw, your arm, and your diaphragmatic. Again, it just follows the phrenic nerve because diaphragm is phrenic. So, or it could be intercostal. So it could be your peripheries as well. So that's for parietal pleura. And for visceral pleura, it's innervated by your pulmonary plexus. So basically your SNS, right? So it's only sensitive to stretch and it's not sensitive to pain. So whenever you have any injury to your visceral pleura, the patient will usually present with a dull pain and poorly localized. So the patient will usually present with pain which they cannot generally point to, like they can't point to a specific location. Yeah, so that's how you distinguish between parietal and visceral pleura. All right. Okay, so your flow of lymphatic, now I think you need to know is that you just need to know a general sense where your lymphatics flow from. So basically your lymphatics start from your visceral pleura, your lungs, and then they are drained into your bronchopulmonary pilar nodes, which let me just try to annotate. So basically it flows into here, these areas, and then it flows into your superior and inferior tracheobronchial nodes, which are these two. Okay, and then goes upwards basically, passes through the paratracheal nodes, and then you'll go into the right and left bronchomediastinal lymphatic trunks, which are here and here. And basically that just directs them to either thoracic duct or to your right lymphatic duct. And that's basically all you need to know. So it's just a pattern of flow. Okay. So yeah, moving on to your sternal angle. So this is very important, and I think you probably would have learned this last year during cardio as well. So sternal angle is your angle of Louis, and mnemonic that you need to know is red lung. Okay, so where is the sternal angle actually? So it's like your second costal cartilage and T4, T5 vertebrae. So you'll possibly learn it when you do your examination, but it's where that when you move down your chest, you'll feel something slightly jutting out. Okay, so that's your T4, T5 vertebrae and your second costal cartilage. Okay, so locate here a very, very, very important landmark, and it's also known as the Transthoracic plane as well. And if you were to learn it through examination, it's basically a surface landmark where it's the joint between your manubrium and your body of your sternum. And we'll have quite a few important things, basically your rib, your second costal cartilage is here, your aortic arch is there, your tracheal bifurcation. So in relation to your respi, this is the most important thing, your tracheal bifurcation, and you'll have pulmonary trunk bifurcation as well. And another thing is that you have your left recurrent laryngeal nerve over here. So, whenever you have hoarseness of voice, it's always got to do with your recurrent laryngeal nerve, when we'll cover that later on. So because it bends around here, you have tendency for it to get impinged, and that affects your voice. Okay, and again, you have your thoracic duct as well as the zygous root. So key mnemonic you just have to learn is red lung. All right, so moving from that, now we'll just focus on a few key conditions that we're going to touch on today, and we probably would have covered quite a bit in terms of the physio side for these conditions. So we're going to focus on COPD as well as asthma. So now we're just going to focus a bit more on the clinical anatomy side of things. So what is the pathophysiology of COPD in the first place? So it's basically a progressive and irreversible obstruction of your airways. Okay, so it can lie in a spectrum ranging from your chronic bronchitis all the way to emphysema. So these are two separate conditions, but they lie within COPD. Okay, so basically what happens, in simple sense, COPD occurs because you have this thing called alpha-1 antitrypsin deficiency. So usually your lungs produce antitrypsin, but in smokers, whenever you smoke too much, this results in this antitrypsin not being formed. And what happens is that usually you have proteases in your lungs, and they can break down your alveoli, your lung, and these antitrypsins stop it. So when you have in smokers, because you have a deficiency in this, you end up having a breakdown of your lung. Okay, so in chronic bronchitis, it's basically your narrowing of your airway lumen. Okay, and you have excess mucus production. Okay, and in emphysema, you have your destruction of your airway spaces. And so what happens in overall context is that you have a decreased elastic recoil. Okay, so your airways are basically collapsing and you're trapping air. So we've learned about air trapping in physio, right? So now imagine you have got hyperinflation of your lungs because air is trapped. You've got increased airway resistance, and you've got an airway collapse. So this leads to hypoxia, which means not enough oxygen. And when there's not enough oxygen, this leads to increased vascular resistance in the lungs, and that leads to pulmonary hypertension. Okay, I hope you can follow that. Yeah, so that's basically COPD. And moving on, so COPD can then be characterized in terms of two different presentations. So your chronic bronchitis is usually your blue bloaters, and your emphysema is the pink puffers. It's just a way to remember it, because people who come in with bronchitis are usually more bluish. Reason is because they have decreased ventilation it's increased CO2 retention. And so this increased CO2 retention leads to, and plus on top of that, you have decreased VQ ratio. I'm not going to go into details about that because I'm sure none of us covered that. So when you have all of this, you basically have a lack of oxygen and they appear blue. And for pink puffers, on the other hand, they hyperventilate because they have decreased CO2, right? So they try to hyperventilate to get in more oxygen and get rid of the CO2. And when they hyperventilate, they end up using their accessory muscles. Like your accessory muscles are the muscles around your shoulder area in order for you to breathe. And they tend to be more pinkish in nature because you're increasing your work of breathing. Okay. Now moving on. So usually for COPD, again, it's obstructive disease, right? So it's irreversible FEV over FVC ratio. So it's less than 70%. And we've got other clinical features. So you've probably got you've got a chronic cough, you've got worsening shortness of breath, because again, your airways are being constricted, so that leads to shortness of breath. And because your air is being trapped in your lungs, you've got a hyperinflated barrel chest. So most of the patients come in usually have a large barrel chest, and they have a wheeze as well. And a key distinguisher between this and asthma is that spirometry shows a decreased FEV1 over FVC ratio, but it's not reversible by bronchodilators. So one key thing you need to know, whenever you see a stem or see anything, you have to look out for bronchodilators. It can be reversible by bronchodilator. It's not COPD. It's usually more likely to be asthma. All right. Now moving on. Now we're going to focus a bit more on asthma here. So asthma is actually an allergic disease. So it's actually an inflammatory disorder that causes reversible bronchospasm, airway obstruction. So what's basically happening is that you've got hyperresponsiveness of your airways, and this is because it's related to your immune system. So I'm sure you've learned this in year one, and you'll probably touch on this in year two as well. So your immune system is got T helper cells, and T helper cells can induce two different kinds of responses. So T helper 1 cells induce IgG response, and so for organisms that predominantly TH1 that predominantly respond by producing TH1, they usually resistant to allergic diseases, but they're more prone to helminth infections. Okay, this is just a trend that people have noticed, and it's vice versa for organisms that respond with TH2. So basically, higher levels of TH2 cells lead to allergic conditions. So asthma is one of it. So TH2 induces an IgE response, and it causes sensitization of the airways and causes bronchoconstriction. Okay, so asthma is basically something it's something related to any allergy that usually related to either intrinsic or extrinsic, and the extrinsic form of asthma is basically related to allergies. Okay, so one key thing about asthma, if you move on to the next slide, is that usually patients present with not just asthma, but this thing called SOP triad. So usually people come in with asthma, allergic rhinitis, allergic dermatitis. So basically anything, once you notice, oh, this person has allergic rhinitis, they have a higher risk of actually having asthma. Because again, it's just this allergic response where mast cells are degranulated due to IgE being produced. Okay, so that's how asthma is usually presented. Okay, so there's two ways that can trigger this IgE. So I was talking about intrinsic versus extrinsic. So if you talk about intrinsic, it's usually like non-allergic. So it could be exercise, cigarette smoke, aspirin, beta blockers, non-allergic conditions, factors, right? Whereas for allergic factors, it's triggered by pollen, dust mites, whatever not. But both of them have the same pathophysiology. Both of them produce too much IgE and then result in mast cell degranulation and then causes your bronchoconstriction. So your people presenting with asthma usually will have a wheeze. So a wheeze is usually because their airways are constricted. They cough because again you can't breathe properly, and just again difficulty breathing, and chest tightness because your airways are being constricted. And one key thing you need to note for asthma is that it usually presents in a TOTI triad. Okay, now moving on to investigations for asthma. So we usually use expiratory flow, right? Or pulmonary function test, which you have gone through in physio. So usually you use a peak flow meter, and it's more useful for assessing exacerbation. But in order for you to diagnose asthma, you usually use your FE1 or FEV over FVC. Okay, so if the result is positive, if you have these following conditions, so your ratio must be below 80%, and there is increase whenever you use bronchodilator. Okay, so the key difference between COPD and asthma. Okay, so now moving on to the therapy. So a key thing that you'll learn, and you'll probably have to do something related to this, an activity related to this in week 3 as well. You start off by giving them SABA, and then you move up the chain. You can't jump straight to giving them oral prednisolone. Okay, you need to follow this chain. You need to start off with SABA, and if it doesn't seem to work, then you add on inhaled glucosteroid. Then you'll add on a LABA, and then if that doesn't work, you'll increase the dosage. Okay, and then you'll probably add on piperacillin, oral GCS, and worst case, if it's really severe, then you'll add on a prednisolone. Okay, so you just have to remember just following the chain. Okay, so now on to something completely separate. So that was asthma and COPD that we have covered and touched on. Hopefully that makes things clearer and helps you distinguish how to distinguish when patients present with either asthma or COPD. And now I'm just going to touch on some key clinical signs that you possibly go through and during your tutorials. And I found it hard to understand when I was learning it last year. So hopefully going through it now will make it easier for you. So you'll learn this thing about vocal resonance during your examination. Okay? So vocal resonance is usually like you hear it through your stethoscope, and it's basically testing you about the speed of sound. Okay, so sound can actually travel faster in fluid than air. Okay, so whenever you have increased vocal resonance, it's due to consolidation, and when it's decreased, it's when there is an air buildup. Okay, so let's talk about increase. Let's give you some conditions for increased consolidation. So pneumonia is basically whenever you have an infection in your lung and there causes a consolidation in your lungs. Okay, so what happens is that you have a fluid buildup in your alveoli, and this actually conducts sound way faster than usual. Okay, so it doesn't change the distance between your lung and your chest wall because the infection is within your lung. Okay, and there's now added fluid. So basically, there's increased vocal resonance. So you'll seem louder when you test this. And when there's decreased vocal resonance, it's the opposite. Basically, in pleural effusion, we covered it last week. You know, there's fluid buildup outside of your chest wall, outside of your lungs, right? In your pleural cavity. So there's a greater distance between your lungs and your chest wall, and there's a decreased transmission or vibration. Okay, so similarly for pneumothorax is basically when there's air buildup between your lungs and your chest wall. And again, it's a error again in conductor sound, greater distance between your lungs and your chest wall. So these two are factors as to why there's a decreased vocal resonance. Okay, so this is key when we try to distinguish different conditions, which I'll be going through next. So these are a few clinical signs, and these are like buzzwords and more like that. And I know some people may focus on memorizing the keywords, and you can go ahead doing that. But I found it easier trying to interpret and understand why you had these key conditions and key like clinical signs, and help me distinguish between the conditions. So for COPD, we went through that earlier. Basically, you have a cough, and it's worse in the morning. Okay, so why is it worse in the morning? It's basically because there's a few factors. Like usually, you're resting throughout the night, and you start exerting yourself again in the morning. So it's worse. It's worse on exertion. Okay, so on top of that, you have dyspnea, wheeze, and the key thing is that it's a past smoker. Because remember what we've learned, smoking results in your antitrypsin deficiency. Okay, and for asthma, it's a cough which is worse at night. So usually your allergies act up at night. Okay, so your cough tends to happen more at night, and it can come about from exercise. And a key thing is that you have a history of atopic triad. Again, a history of like allergic reaction. Okay, and for pneumonia, you'll have a heuristic testing, because I'll touch more about pneumonia and all of these key conditions next week. But again, these are just buzzwords that you need to focus on. So heuristic testing, it's basically testing upon inspiration and expiration. Okay, because it's rubbing against the pleura, right? So whenever you have that kind of chest pain, first thing you got to think of is it a pneumonia or is it a PE? Okay, so you'll have dyspnea and you'll have a dull percussion. Okay, so that's the key thing you need to know, dull percussion. And again, it's related to your vocal resonance, and it just relates to how sound travels faster into it rather than in air. Okay, so again, moving on to tuberculosis. It's quite rare to have tuberculosis in Australia, but a key thing that you have to look out for is recent travel from a country of higher risk. Okay, and PE is basically pulmonary embolism, and like I was saying earlier, you have your thoracic chest pain, you can gain upon expiration, inspiration, and a key thing is recent surgeries. So usually you get pulmonary embolism. So how do you get pulmonary embolism? It's after a surgery, you tend to be hospitalized for quite a while, and you see immobilization or even a long flight can result in clots forming in the blood. And these clots can flick off through the blood and travel all the way up to your lungs. And once it enters your lungs, it's known as pulmonary embolism. Yeah? So usually DVT can lead to PE. So moving on to pleural effusion, we've got stony dull. Again, this is due to the air buildup, the fluid buildup, and you have absent breath sound. Okay, and finally you've got your pneumothorax, and that's a sharp, rapid onset chest pain. And the reason why is because pneumothorax is usually results from trauma. So there's usually a patient presents in with a sharp pain, and you can ask them, "Oh, did you recently get injured in the chest?" And usually, whenever they mention something about a traumatic incident, you tend to narrow your focus towards pneumothorax. Yeah. Okay. So these are key buzzwords, but I'll go into more details about some conditions that you need to focus on next week, and we'll try to test you on the buzzwords again next week. Yeah. So now moving on, I've just got a few questions. Test you on your clinical anatomy. So you can just type in the chat, and you can see how you go. So yeah, those things that we covered last week. So food that aspirate into lungs are more likely to enter which bronchus? Your right or left? Okay, great. Yeah, so right. Because remember we learned that your right is shorter and easier for food to travel into your right bronchus. Okay, how about your next question? The left hilum, how many arteries are? Is it going to be? Remember we learned the acronym RALS. So are the arteries going to be anterior, inferior, superior to the main bronchus? Okay, so someone said anterior, so close, but so you got to remember your acronym. So RALS, so right is anterior, left is superior, and this is your arteries in relation to your bronchus. So in your left, your arteries are going to be superior to your main bronchus. All right. So then moving on to your parietal pleura, is supplied by your phrenic nerve as well as your yeah, great. So intercostal nerve. That's great. Yeah, and then so next question, your continuity between parietal and visceral pleura is known as what is the thing that Lazarus always likes saying? Do you remember whenever you have a looping of your parietal and visceral pleura, you actually form this thing known as your ligament. Yeah. So a ligament is whenever your parietal and visceral pleura attach to each other, and it's in the case of your lungs, it's known as a pulmonary ligament. Yeah. And in lungs, this is another key thing you need to know. So your lung, where does it extend to? Anteriorly, laterally, and posteriorly. So you just need to know your key level. So remember the rule of two. So where does your lungs extend to? Okay, so quite close. So you need to know the difference between your lungs as well as your pleura. So your pleura is going to be the one extending lower. So your lungs are the ones which are smaller, right? So it's going to be, for lungs it's 6, 8, 10, and for your pleura it's going to be 8, 10, 12. Okay, just need to know a key difference there. The lungs are the ones which are the ones which are smaller. So what passes through your cable opening? Again, this is something which you might have touched on last year, and we went through last week as well. So related to the openings in your diaphragm. So there are two key things you need to know. Okay, so yeah, not bad. So yeah, there's going to be your inferior. Yeah, that's good. Someone got it right. So inferior vena cava, as well as your phrenic nerve. Okay, so these two key things. You need to know the structures that pass through your opening. Okay, so then last question of the day: what will investigations show for an asthmatic patient? So what's one key thing that we've been talking about in terms of your ratio? Is it going to be increased? Is it going to be the same? Is it going to be decreased? Yeah, good. So you just need to know that you'll have a decrease VQ ratio. Yep. And that's basically all the questions I have for today. Yeah. Yeah. Does anyone have any other questions?
Nope, that's all. Thanks.
All right. So let's just end it for today.
Yep.
Thanks, guys. If you have any questions, just send us a message. Or you can watch the recording as well.
Thanks, Ajay. Thanks.
Thanks. You guys.